It's about 1 after. We'll get going. Welcome to our first of our 2-part Lunch and Learn series here on the second substitute Senate Bill 5195 for behavioral health agencies. And I just want to, before we get started here, I want to acknowledge that I'm speaking to you from Tacoma, the traditional and ancestral lands of the Puyallup tribe. Prior to colonization, this area was a vibrant community of the Salish Coast people, including the Nisqually, Puyallup, and Saquon Island tribes. I recognize the people and communities that live on and care for these lands and have since the beginning of time. This land acknowledgement is one small step in true allyship, and I commit to uplifting the voices and experiences, as well as the histories of the Indigenous people of this land and beyond. I honor and thank their ancestors and leaders who have been stewards of these lands and waters since time immemorial. And I commit to caring for the land, waters, plants, and animals. I encourage each person on this webinar to learn more about the Indigenous people who inhabited and cared for the land where you now reside. Thank you. I also want to make a note that we are recording this training and we'll make it available as well as PowerPoint slides afterwards. Some housekeeping here, nothing new for folks, but everyone's muted. We ask that you stay muted. And that if you have questions, which I'm sure you'll have, or comments, please put them in the chat box. I have an HCA colleague monitoring that chat box, and we'll take down questions throughout and circle back here either later in the webinar or afterwards if we don't have time to address it here. Again, I put my information at the very top, so feel free to also email me and I'll be giving more resources and information as this goes on. So without further ado, let's talk about who's talking to you today. I'll introduce myself. My name is Laura Meter. I'm the Overdose Reversal Medication Program Director at the Washington State Healthcare Authority. I'm leading the Department of Behavioral Health and Recovery's work stream on implementation and providing technical assistance and education on Senate Bill 5195. And this is to behavioral health agencies that are impacted like you all, as well as emergency departments across the state. You'll be hearing quite a lot from me today, but I also want to take the chance to introduce my colleagues and my collaborating community partners. So up first, Mandy Slatke. She's an advanced practice nurse specialist in substance use disorders for Public Health Seattle King County's overdose, prevention and response team. You'll hear a lot more from her as well next week on the second part of this 2-part series around clinical considerations. And then also I wanted to take the chance to introduce Miriam So. She's the lead nurse at We Care Daily Clinics, who will be speaking to us today about their process and program. We Care Daily Clinics is a collaborative operation. It's overseen by the Muckleshoot Indian Tribe and is one of the leading office-based opiate treatment programs in the country for Native Americans. It's also nationally recognized by the Pew Research Center in Excellence for Behavioral Health Care. So we're really thrilled to have both of these collaborating partners with me today to talk to you about this new law. So this session again is specifically for impacted behavioral health agencies. We won't be going into requirements for emergency departments on this webinar. If you want additional information specific to ED implementation, please reach out. And the majority of today will focus on aspects of implementation, including approaches on how to partner with pharmacy, as well as considerations in developing agency policies. And just to level set, make sure we're all using the same terminology here. The law refers to overdose reversal medication. The medication we're referring to there is called Naloxone. Sometimes you'll hear it referred to also as Narcan, which is the brand name nasal formulary. And you'll hear it in all these different ways presented here and also as you read through any of the references and resources. So just making sure we're all speaking the same language. So Mandy, let me hand it over to you for a brief overview on the background and context of the law.
Great, thanks. Hi, everyone. So I do want to provide some context about why this bill is important and how it came to pass. So drug overdoses, as some of you may know, both nationally and locally have been absolutely soaring in the past couple decades, with particularly really sharp increases just in the last several years. We are seeing 100,000 people dying annually in the US from drug overdoses. And as you can see here in the charts, that opioids and stimulants are really driving these deaths. The opioid fentanyl is causing dramatic increases. You can see that on the left in the kind of the dark orange color. That synthetic opioids category is primarily fentanyl. So those are our national numbers. And then on the right, you can see the numbers local to King County. I know we have people from all over the state today, but just as a frame of reference for a little bit more local context, you can see in the blue, purple, and the red, those are our opioid and stimulant related deaths. So that makes up a majority of the overdose deaths. And you know, many of these deaths are preventable with harm reduction education, treatment access, and naloxone. So that's why this bill is so important and how it came to pass. There were many people who are not accessing naloxone, which we could see from Medicaid claims data. And then we have insurance that's an already available and sustainable payment method for naloxone. So we're really trying to de-emphasize this reliance on grant-funded sources and move to a more sustainable payment method with insurance. And we do know, above all, that widespread dissemination of naloxone is safe and it saves lives. So I'll hand it back to Laura to talk about implementation of this law.
Thanks for that great overview, Mandy, and just the framing of why this is so important and also why it's really an exciting opportunity to help save lives and support the clients you're working with. So jumping right into the overview of what this law, which is quickly approaching being a law here, January 1st says. So what does this mean? Here's the high level requirements to be aware of starting in January for impacted agencies. We'll take time here briefly to jump into all of these in more detail. And let's briefly review which behavioral health agencies are impacted by the law. You may be wondering, does this apply to me? I want to know. That's why I'm on this webinar. Overall, it's all opiate treatment programs, OTPs, and all licensed or certified behavioral health agencies that might be providing treatment for mental health, substance use disorders, secure withdrawal management, and evaluation and treatment. So that's the high level definition of who's included. We do have resources at the end of this presentation as well that you can go into the RCW and understand better how the law defines BHAs and impacted agencies. All right, so let's take a minute to break down those requirements I flashed up earlier in more detailed steps. The first thing required of your agency will be that you identify clients at risk of opioid overdose and ensure that they have naloxone and that they know how to use it. So the definition here for inclusion includes clients that present with symptoms of opioid use disorder or OUD, and then also those that report use of opioids outside of legal authority. So you know your clients best, you know the communities you're working with. When you're thinking through identifying individuals who report use outside of legal authority, this number 2 on the top bubble, best practice is if your clients report using any pills, powders, or other drugs that they've gotten from the streets, from friends, or even from the internet, they're at risk of overdose. And that partly is just framed for what Mandy referenced earlier based on fentanyl and other high potency opioids now. So really just so they know, anyone, again, I'll say it again, anyone of your clients reporting use of any pills, powders, or other drugs from streets, friends, or even the internet really should be offered and assessed and offered naloxone. And then once you've assessed it, if they're appropriate for naloxone, if they meet those criteria, then you'd ask them if they have it already. If they don't have it, this is where the law is new and nuanced potentially. So if they don't have naloxone, your agency will assist them in getting it by either prescribing it or using the statewide standing order and then assisting them in directly obtaining the naloxone as soon as practical. And that means kits in hand, not simply a paper or electronic prescription. So when does this need to be done? The law, when is January 1st, but in the workflow, the law builds in 3 identified clinical opportunities where agencies can complete this required identification and distribution or dissemination of naloxone. So These are at intake, at discharge, or at treatment plan review. And these are minimums called out in the law. They're not necessarily best practices or, as you know, your population, the workflow and how it would look. It'll be up to your agency to determine what makes sense for your population and your workflow. I like to put in here that best practice, depending on the population and the focus of your treatment, may be to integrate screening and assessment into all three of these domains, not just one of them, and then make sure that's outlined in your agency policy. As we know, people's experiences with substance use, as well as opioid risk and overdose risk, is not linear. It can change at any time. And naloxone kits get used, they expire, they get lost. Ideally, they get used and they save lives. So they're checking in as frequently as appropriate for your population makes sense. And then there's also billing requirements discussed under this law. The intention of the billing component of this law is to maximize resources, as Mandy was talking about earlier. When organizations who can bill insurance do so, the availability of grant-funded naloxone for programs without billing capacity increases, therefore increasing overall access to community naloxone. And then the last pillar of requirements, I know those are fun to cover, is really around education. So it's saying get a kit in hand if it's appropriate, make sure we're billing for it, and then also make sure we're educating clients on how to use it. So it's directions for use, but also additional information and resources on medications for opioid use disorder and harm reduction strategies and services. So HCA will provide these educational materials in applicable languages by the 1st, as outlined in the law. And we'll talk about more current resources that are available and how you'll be also accessing those documents I just referenced a little bit later. I'm really building up the resources, and so you get excited for the end. And then just a really quick note on labeling. So a note on prepackaged naloxone labeling, existing requirements as outlined here on the screen are not applicable for directly dispensed naloxone under the law. So the intention there is by removing or not requiring the same labeling requirements, there's flexibility in how this can be implemented and for your organization. So let's dive into distribution approaches. This is like the how to do this in some ways and how the law outlines it. There are several approaches for directly obtaining naloxone for clients, and it as outlined in the law itself. I want to recognize that many of you on this training today are already doing this, are experts at this, provide naloxone already to clients and have expertise in understanding how to assess for this. So hopefully you can build on that as well as potentially use models that we'll talk about today. And then I also wanted to call out the last bullet on here that mentions the HCA bulk purchasing and distribution program when operational. So the law talks about that as soon as reasonably practical, HCA will establish a bulk purchasing and distribution program for naloxone. That's really a long-term solution that the law outlines, and that work stream is underway right now. But until the program is operational, your organization will need to utilize one of these other outlined distribution approaches. And regardless of the approach that fits best for your organization, a relationship with pharmacy is critical. So that's why we're spending a little time here really talking about pharmacy partnerships. More resource prep here. We will provide you additional pharmacy partnership resources at the end of this presentation. We want to encourage you to establish, build, and strengthen those relationships as your agency moves through implementation. You may already be working with pharmacies, especially if you have on-site or hospital pharmacies, outpatient pharmacies, and many organizations already partner in the community. But this is also something I want to call out. This is really what behavioral health agencies do best, working in the community. You develop community partnerships and relationships, and you leverage those to really positively impact the people you're serving. So this is in your wheelhouse and something that I feel strongly that behavioral health settings are champions at. For review, also on this slide, I want to just briefly cover the statewide standing order. This can be used in general, just as a like an overview. The statewide standing order in Washington State can be used as a prescription for naloxone. So people, individuals may take the standing order to a pharmacy and get naloxone instead of getting a healthcare provider to get a prescription for them. But relevant to the discussion today on agency-wide implementation, organizations may also use the standing order in Washington State to get naloxone and give it to people who are at risk of overdosing, or people spending time with people who are at risk of overdosing. And you'll see, we're going to talk, we'll actually just hear from Miriam, so in just a few minutes, about how they use the statewide standing order as well. If you don't have a prescriber on site or you choose to work with a community partner, the statewide standing order is an important thing to familiarize yourself with, and we'll get more resource information on that later as well. And with that, Miriam, I know you were connecting. I just want to confirm you're here. I want to introduce you and hand this off to you to talk about what you're doing so well at We Care Daily Clinics.
Hi, everyone. I'm Miriam. I'm here. Hi, Laura.
Hi.
All right. Here at We Care, we are utilizing, with partnership with Genoa, we're utilizing the prescription All right. At We Care, we are able to provide naloxone and Narcan to our patient before through a grant, but it wasn't enough. So we moved to partnership with Genoa. With that partnership, we are able to use the standing prescription through the state with after the MD see the patient and establish their need for naloxone and Narcan. Those patients are sent to the window, and with the nurses, we do provide them with the form, the general form that they fill out and sign and give us consent to send that prescription to Genoa and have them send the prescription to us, to the clinic. And that is done. Usually when we send it to Genoa, it's we get the medication the same day or the next day, which is a very easy process for the patient, because they don't have to go to the pharmacy and to get those medication. And Genoa been really helpful and fully covering the copay for the insurance.
Miriam, is it okay if I show them some of the slides with the packet that you were talking about, the enrollment packet? Okay.
Sure.
So just to get an idea of what this looks like for folks right here. This is your enrollment packet, right? Giving consent. Mm-hmm.
Okay, we can go through it. And this is the second part. Yeah. The first part where they have signature and date, that's where the patient signs, and then we fill out the rest with their information, which will include insurance, or if they have private insurance, or if they have Medicaid, those information are filled out there and faxed to Genoa. If they are Medicaid covered, so it's at zero cost to them. But if they private insurance, they might have a copay that might be as high as, I saw one time, $100 or even more. So it depends of their insurance coverage. And most of the time we help them at the clinic to pay those copay. What is the next one? Next slide.
Yeah, this is the process. I think you walked through it really nicely, but just talking through about them signing this and then faxing the form and just sort of the step-by-step here that's up on the screen.
Yes. So what we do once after filling out the confusion, filling out the consent, sending it to the pharmacy, having those medication delivered the same day or the next day, those medication the next day. So we get those medication. Once we get those medication, we give it to the patient with the education of how to use it and how to store it safely, and within access to anybody who might need it at that time, either for them or anybody else who will be around.
And then this is your pharmacy contact, is that right?
This is, yeah, Dr. Butler is our contact with Genoa for anybody who might have a question regarding this process.
And then I think you did a great job. You covered this already, but this is around the your experience of seeing the zero, working and billing insurance with this process.
Yes. Medicare covers most of the time at zero copay, but since for those people who's unsure or have private insurance, most of the time is not covered at 100%. They always have a copay, and Genoa being really good at reaching out to us and letting us know if there is a high copay, if patients are able to pay or not. But if it's a high copay, usually we just take the cost to be able to provide those the naloxone to the patient.
Excellent. And any other things that you think would be useful just around around sort of like the process or best practices you've learned in this way, or things just before we move to other distribution channels, Miriam?
Connecting and connecting the farm to the pharmacy, making sure that you have a good partnership with the pharmacy is the key.
It sounds like you've really established a great one with the Genoa. So thank you so much. And also, if you have questions specifically for We Care Daily and how that's working, you can also put those in the chat or feedback, and then we'll address those, and we can also Miriam can speak during question and answer to specific questions as well about how they are rolling this out and successfully giving people naloxone and also billing for it. So thank you so much for that. We really appreciate you presenting on that today.
Okay, thank you.
So again, thank you, Miriam, and please ask questions specific to her experience or the We Care Daily experience. They're doing a great job there. These up on the screen also are the other two main distribution approaches we talked about or I previewed earlier and that are outlined in the law. So on-site pharmacy, if you have an on-site pharmacy, you're part of a hospital system, even if it's an outpatient pharmacy that's on a hospital property or campus, you can use that. it's just to note, as part of that, you're going to need to make sure that your policy development talks really about the process of delivering, ordering, and receiving the medication. So that's an area of policy development. We'll get into policy development in a second, but specific to on-site pharmacies as well. And then alternatively, the law does allow agencies to meet these requirements through mail order pharmacy. So that means directly working with the client's mail order pharmacy and getting it shipped to their home, or getting it shipped to the agency to be further distributed to the client if they come back the next week, for example, for care, or the next day, or later that day, however the pharmacy mail order agreements work for you. So let's dive in a little bit more and move into considerations as your pharmacy, or as your agency rather, develops its policies and procedures. So it's figuring out what will work, but then how do you make a policy around that? And I want to briefly touch on areas of policy development. So up first here, standardizing a screening and inclusion process. When will this take place, for example? Again, minimums call out in the law that'll happen at a minimum at intake, discharge, or at treatment planning, but what will work best for your organization, and making sure your policy reflects that. Further considerations are for new patients versus existing patients starting January 1st. So as you take, new assessments, for example, but maybe you have a whole caseload of folks that need to also that are subject to this law as well. So how will you implement that? And then of note, the law does not outline a minimum age requirement for screening. So I have been receiving questions around, does this start at age 10 and up, or 5 and up, or what if you serve youth or pediatric populations? It does not outline the age. So just know your population and know your clients, and whoever meets those criteria as far as who's at risk of opioid overdose, and that can happen earlier and earlier as we're seeing, will benefit and be subject to this law as well. So moving into documentation, this is I think the phrase I've always in clinical work heard: if you didn't document it, it didn't happen. Documentation is critical. Documenting how, when, and who will do it, do the screening and distribution of the naloxone. And then just a few pieces of feedback there. If you use an electronic health record in your place of work or at your agency, you can create standard templates or dot phrases. If you're part of a larger hospital system that's implementing this in an ED capacity, you may be working with your Epic or electronic health record team on finding standardized protocols there. If you use paper assessments or you're out in the field, you can also revise or add screening protocols as part of the paper documentation. So just generally, the more, as many of you know, the more standardized ways of including this into your workflow, the more consistently it'll be utilized by staff. And the hope is then more accurately and more inclusive of giving out this medication to those that will benefit from it. And then just really talking briefly about exceptions and considerations. Make sure that your policy and procedures reflect exceptions. The law does talk about that kits don't need to go in everyone's hand every time. An example is if a client already has naloxone, even if they meet criteria, you check with them. They say, yes, I have it. I know how to use it. It's not expired. They don't need another kit every time they come in to have a therapy session or see you in clinic. However, this is the big asterisk, kits get used, they expire, they get lost, other people use them. So finding ways as you build out your policy and procedure to offer kits or check in with people frequently that are using or have naloxone kits is best practice. And then also just want to make a note, I've had a lot of questions if clients are allowed to refuse medication. So under this new law, just like any service or other medication, people have the autonomy and right to decide to refuse a medication or not use it if it's not appropriate. We will provide educational materials, HCA, I'll talk about that in a second. And there are a lot of existing resources for staff trainings that might make it easier and facilitate staff feeling more comfortable talking to people about the benefits of carrying and receiving naloxone, especially if their clients are at risk of overdose. And then this last part here on the screen, internal quality assurance. So When and how do you review lessons learned? How are you planning to measure success around this and know what your organization is doing? And then here are a few additional high-level considerations. We're talking about workflow. So what happens after the client is initially identified? You've come up with a system or a process when you're going to do it, then what, right? When will the client receive the training and education materials in the workflow? Is it when they get the kit? Is it right when they're identified? If there's a delay in getting the kit based on your distribution channel? What happens if they don't show up and pick up their kit? If you use a mail order to your agency, for example, and there's a delay, how do you keep people safe in those interim stances? And then storage consideration, inventory, access, tracking, some of those just basic fundamentals. And then staffing, this is a big one. Who's going to be responsible? So every program is going to look different because every agency looks different. And so you know what's going to work best for your organization. Which frontline staff are going to implement this, and how are you as an organization planning to message and train staff? That leads into this next bullet here. So training. Staff education and training, things to think about as we've all done with other initiatives, but frequency, how to staff existing versus future and new staff. Will you do it annually? Will you put a competency in their staff chart? What are the methods? And just to note, there'll be more of this as far as educational domains and critical considerations covered in next week's part 2 of this. And then finally, sustainability of a program. So putting all of these pieces together and hopefully putting someone or a committee in charge of it, making sure you have a succession plan so that this is a sustainable program that continues even if staff changes and moves. And now we'll just check in on technical assistance and resources here. So the HCA webpage we are developing for the Senate Bill 5195 will be up in January, and you'll be able to access all technical assistance materials as well as educational documents. We'll also have a toolkit for behavioral health agencies, which will give sample materials, including staff training and even sample policies. And now I know the timing of that would be great if it was yesterday. But as you're working on things, we just want to help at HCA and otherwise to help support your efforts in implementation. And we're here for you for additional training and support. And so if you are interested in additional training, whether that be staff training or just to go over some of these questions that you have, please reach out to me. My information is listed here. If you have pharmacy specific or billing questions, especially related to Apple Health, Medicaid, this is the contact information, and those work streams will also be checking on those. So you can reach out specifically to Apple Health pharmacy policy at HCA. And now I've been really like hyping up these resources, so I hope they deliver. But we just specific to this pharmacy partnership, I wanted to make sure we had these listed. This is additional information on the statewide standing order, including copies of the statewide standing order, frequently asked questions, and further information located on the Washington Department of Health website here, listed here. Fabulous resource. And then another wonderful resource at stopoverdose.org, excuse me, from our partners at the University of Washington ADAI. They have a locator there for Naloxone, but also just tons and tons of information as it relates to this. And they just most recently put up a page about this specific law. And then also listed here are known pharmacy partners who are already doing this or willing to work with or excited to work with organizations in King and Snohomish County. Especially I want to call out Kelly Ross in King County and Credenza Health Pharmacy Monroe in Snohomish County. And then of course, Genoa, who was listed earlier. If you are a pharmacy partner on this training and would like to share your contact information, feel free to put it in the chat or send it my way, and I will also make that known. But just wanted to put those names up there, and feel free to reach out. And then just tons and tons of existing excellent resources from partners and people doing this work already, including yourselves in the state. And again, just to note that the HCA translated educational materials are anticipated to be ready by January 1st, and we'll push out that information as soon as we have it. And more resources and also legal references for folks to take a look at. And then just want to also put the save the date for next week, same time, same place. This one will be Mandy talking more than me and really speaking to the clinical considerations. This is a great opportunity, especially for frontline staff and others to join if they are able and learn more. And now I'd love to hear from you, and we would all love to hear from you. So I know I asked for questions to be put in the chat. I have a colleague, Liz Wolkin, who's been collecting some of those questions. If you have more, feel free to put them in now. And Liz, is there anything that's standing out or themes, things that you'd bring up at this time?
Laura, yeah, we had a couple of questions that have to do with prior authorization. So are all insurance companies, private insurance as well, required to pay for naloxone under this statute without prior authorization? There are concerns that potentially the prescription would be denied.
Liz, I'm going to interrupt you for a second. It's really difficult to hear you. A lot of people are saying in the chat they can't hear you.
Is this better at all?
A little bit.
I did hear questions about prior authorization, I believe, right? So will the medication be denied if it's not a if the patient doesn't have Medicaid? Is that the question?
Yes,
overall?
and I will call in. Can you hear me now?
Yeah, it's a little better. Mm-hmm. Okay.
Okay, well, like I said, I will call in just a second, but the question is yes. Regardless of insurance, is there any possibility of this being denied because of a lack of prior authorization?
Okay. And Mandy, I know you had something listed earlier on prior auth. Is that one you feel comfortable taking? If not, I can circle back on it.
I only know about managed care organizations.
Okay.
I don't know about otherwise.
Fair enough. So I don't know as far as all commercial payers if there will be denials or needing to run prior authorization for this. That's a really great point and question, because that could create a lot of trouble for organizations trying to accomplish this depending on their client payer source that they're working with. So thanks for bringing that up, and that's something for me to circle back on and get back to everybody here. And then I just saw something maybe while Liz is calling back in or logging back on from Shirley. What if you do not have a prescriber? So that is part of what we covered a little bit earlier. And again, these slides will be made available, as will this recording, but around utilizing the statewide standing order. And so Miriam, are you comfortable talking about that at all too, from a We Care Daily standpoint on how, or is I believe you were covering that the standing order, which we flashed up there, and Genoa is utilizing that as your pharmacy partner to get naloxone without a written prescription. Is that right?
Yes, that's what we do. We use that standing order. We don't have to, the provider doesn't have to send a written script anytime to fill those the naloxone. So those standing orders are the one that we use, and it's been really helpful.
Great. Thank you. I just saw another one in the chat here from Dave Cundiff. I'm sorry if I'm butchering your last name. Are behavioral health agencies responsible for making sure patients know how to use naloxone kits that they're obtaining? So yeah, that's part of the requirement around education. So you're responsible for providing directions for use, as well as information on medications for opioid use disorder and harm reduction services and strategies. We'll have all of those materials for you that you can give to patients or clients. The step-by-step instructions per se for behavioral health agencies, they're required to provide that. In best practice would be to be able to walk through that potentially if you're if you're the therapist or you or the intake coordinator, whoever is talking to the patient, and really taking the time to educate them on it. And at a minimum, it's to provide them with that information. Thanks, Dave. Okay, Liz is back. Liz, did you have anything else, some like sort of themes that you pulled out today? And then we can also open up the lines if there's things that we're missing too for folks that want to ask questions directly.
Jenny Arnold has her hand raised.
Oh, hi, Jenny.
Hi, I'm from the Washington State Pharmacy Association, and I just highlight that for commercial payers, there are going to be some significant barriers with PBM copays or pharmacy copays for naloxone. Some of the plans I've heard of, the copays are $75 to $100. And I think that's where if the patient's refusing it because they can't afford the copay, it's unfortunate, but I think it's unavoidable for the commercial plans. Thank goodness for our Medicaid plans and managed Medicaid plans, that's not an issue. But I just wanted to highlight that and kind of call out that potential barrier for this. And I think that underneath, it was really helpful hearing this presentation and some of the opportunities for pharmacies maybe to deliver the medication to the clinic for pickup at a later date or a second date. And that might help to increase access for sites that don't have dispensing pharmacies. Every pharmacy can fill naloxone using the state standing order. So that's a helpful tool if you don't have the prescriber, where the pharmacist on site can be the prescriber in that partnership arrangement. And then the last thing, which I know is a little bit secondary to this call, but I believe the legislation, especially around emergency room visits, permitted or made available a add-on billing code so that the medical insurance could be billed for the dispensing of naloxone on site. And I was wondering, has there been any movement in development of an add-on code so that the medical benefit could be billed in addition to the kind of capitated fee for the visit? We have a lot of healthcare facilities who are eager to find that out so they can put that into their workflow.
Understandably. Well, first off, Jenny, thank you so much for framing that sort of response and being really clear that yes, there are potential barriers and challenges depending around what payer source you're using, if it's outside of Medicaid. And as an asterisk there, as I discussed a little bit earlier with this forthcoming or longer term solution with bulk purchasing, the bulk purchasing and distribution program, commercial payers will be on board at that future time, but that timeline is not yet established. So back to your second question around ED billing, which is a little bit, like you said, separate from this presentation for behavioral health agencies specifically. I'm happy to circle back with you offline, but that is still in process, and hopeful that we will have that billing information ready by the first of the year. And if not, then there's going to be a process for retroactive payment.
Oh, great. Thank you.
No problem. Anyone else have specific questions, or Liz, if there's things that might be useful that you saw as themes throughout? I just saw something from Veronica here.
Hello,
Go ahead. Yeah.
Hi, this is Donnie Goodman.
Hi,
I'm with the YMCA of Greater Seattle. Good afternoon. I have two questions. One is, we have the CORS team, which does the crisis response for 24 and younger in the county. Are they required to do this?
Offhand, I don't want to speak out of turn. If there was a slide earlier, and then I will also, when we send these out, it'd be good to just cross-reference. Essentially, if they're licensed or certified to be offering and billing for essentially mental health, substance use treatment, secure withdrawal management, or evaluation and treatment, then they would be subject to this. But there are, in those legal resources I also flashed up earlier, there's the RCW, the definition of how impacted behavioral health agencies are being defined, which might be useful for your, to kind of really get into the nitty gritty of that question.
Thank you. And then of course, part two is, this is part of my own movement forward of creating parity or governing parity across private practice and agency. Is this something that's only assigned to agencies, or is this an expectation that people in private practice would have to be doing the same thing?
So my understanding, again, is back to sort of the definition of licensed and certified. So if as an individual, like a social worker, a licensed social worker who's out providing private practice, that would not necessarily count. That said, I appreciate that you brought it up, because it's something, it does not also, people could adapt this. This is the law where it's a minimum, right? And we're encouraging folks and hoping that this really starts positive momentum of making this a normal thing to do, albeit we recognize that this is a challenge and a lift to get some of the policies, procedures, and protocols in place. But the intent of this law, of course, is to get more naloxone out there, and get it in hand rather than just in the prescription that can end up in the trash. When people have it in hand, they're more likely to use it and not have to go through and experience the barriers of filling it potentially and not being at a pharmacy, et cetera. But I appreciate you bringing that up. And of course, encourage those that are in private practice as well to get naloxone to their clients.
Thank you, Laura.
Laura, are you able to hear me now?
I am.
I'm so sorry about those technical issues. I do have a couple theme questions coming from the chat, if I can pop in with one or two.
Sure. Yeah.
So the first has to do with an age range. Is this only for adult patients? Is there any minimum age for this law? Can you just give us some more information on pediatrics and under 18?
Sure. Great question. The law does not spell out a minimum age or for screening, right? The inclusion criteria are as listed if there's symptoms of opioid use disorder, or if there's a report of opioid use outside of legal authority. That was the one that I kind of went over and said, you know, if someone's using pills, powders from the streets or from friends, from the internet, essentially that can happen at a lot of ages. Unfortunately, you don't have to be 18 and over to be meeting those criteria. So if you serve a pediatric or youth population, it does apply to your population as if and when there are cases of people under 18 who meet those criteria, if that makes sense. So if you're finding out the patients that you're working with that are 13, that are 10, are using illicit opioids or other of those drugs that I mentioned, so anything in that scope, then they need to be offered kits in hand as well.
Thank you, Laura. I have another theme question from the chat. What can you tell us about the storage of naloxone at outpatient sites? Does this law allow for like clinics and outpatient services that don't typically store medications on site to change that, provided that it's appropriately secure? Or is there still a barrier to being able to store on site?
No, so, and I don't want to speak out of turn, but there are some clear guidance. There's clear guidance in this law when it comes to storage for emergency departments. And actually, Liz, you could probably speak that off the top of your head, but Liz is a counterpart of mine working on emergency department support. So it's in her wheelhouse. Specific to BHAs, though, it really spoke, I believe the law speaks mostly to waiving the labeling requirement. And it also, if you want to read it, get into it, it's one of the resources listed as well. And I would encourage your organization to get familiar with it as you're basing some of these policies. This is really a high level overview. It really did not outline that you couldn't. So right now, organizations that receive grant funded naloxone, and hopefully my partner in crime here, Sean Hammerly from DOH, is on to check me if I'm wrong, are able to store grant funded naloxone on site. So this does not impact or change, to my understanding, that situation for organizations.
Laura, I had a question for you as well, just kind of to add to that one. So you were saying for grant-funded Narcan or naltrexone that it could be stored maybe an outpatient level, and the storage requirements may not be the same as what it would be maybe in a residential setting. So would that be within including, of course, the standing order, or not including the standing order?
Oh, meaning are there separate and different considerations for the grant funded supply versus what you're maybe filling under this this legal requirement? Is that the question?
Well, with a standing order, that would be the prescription, right, with the instructions. And so you give it to people as if it was like an over-the-counter medication, but the standing order makes it a prescribed medication. So normally when you would store medication, you'd need to have like a narcotic book, and you'd count it 3 times a day. You'd have to be double locked. That's like your basic standards for a social setting where it's not prescribed standing order. Exactly. Like for like somebody that comes like into like a residential setting and they have prescribed medicine that can be distributed to them at that facility, but maybe the prescriber's not there, for example.
I see.
What I was wondering is, can that happen at an outpatient level? And would it include the standing order? Or are you saying under the grant funded medication, it doesn't require a standing order?
Well, I think what this is highlighting is I don't want to misspeak on this and say it's this and it's not that. What this illuminates is that the storage considerations should be fleshed out more, both from my knowledge base as somebody leading the implementation for DBHR, but also to give guidance. So I appreciate you bringing that up. As we're going to have this toolkit I sort of talked about and previewed, this is a great area that I can get more information on, circle back, and also build it out so that guidance is clear and not conflicting with what's existing out there. So thanks, Marcy, for highlighting that. I know that's not the answer for you right now, but this is the value also in having these sort of iterative conversations, because you all are doing this work. You all know your work streams, you know your clients and settings. And so how to make that fit appropriately and how to implement this work is going to look different. And we want to hear, and I want to hear from you as to some of the challenges or potential opportunities you see related to implementing this. So thanks for bringing that up, and I'll have to circle back.
Laura, another theme question we're getting in the chat is about 100% telehealth services and what it is that they can do to make sure that their patients are being supported getting their naloxone. Great question.
So specifically, how would this look in a setting where they meet the criteria as a licensed or certified BHA providing one of these services, but no one is physically, it's all remote? Is that right? I believe in that case, it might make the most sense to work with the client and do mail order. And that's conjecture. That's like a thought. It pops into my head. But also another great actual real life clinical consideration for how this might look given the age of telehealth and what that looks like for a lot of people. So that's what pops into my head right now. But again, we can circle back on sort of best practices around that and seeing how it might work in general. Anyone else have a thought on that? Or if you're already starting to put your guidance together for or policies together and you do majority telework, is there anyone on this that's already come up with a workaround or a solution for that? Hearing nothing, that's fine. We will again, lay it on us, let's hear it. Let's hear what some of these situations are, because while I have a clinical background myself, I'm not in your clinic, and we all come from different perspectives and serving different populations. So this is really helpful. Did you have another themed question or feedback, Liz? As I'm writing all these down as well. So storage.
We have a couple people with their hands up. We have Tammy Baker.
Yeah. Okay, Tammy, go for it.
Yeah, I wonder for behavioral health organizations that have that operate residential services. This might be primarily in King County. If you have cross-referenced this with our licensure requirements with DOH and or DSHS, with whichever body we are licensed with, and the ability for, one of the things in those licenses is that clients cannot have medications in their room. So I'm wondering if you looked at this at all, you looked at those requirements through DOH and DSHS licensing when you were putting this together?
Great question. So specifically, as far as the implementation, what pops to mind right now for me is that as I outlined, there are 3 minimum clinical opportunities for the distribution and facilitation of naloxone in hand. So potentially with residential programs, if that's at odds with the current licensing requirements, as you're outlining, then it might make the most sense to do it at discharge, right? So that when they're leaving the facility, not so much when they're doing their intake. During your intake, you could flag that this individual will meet the criteria, and you can facilitate the kit in hand when they leave at discharge. So that's where the flexibility comes in, and the opportunity for you to make this, or not you, Tammy, but all of the organizations, to really make this work as best as possible based on your workflow. So it sounds like it would be more appropriate to do it at a discharge. Does that make sense?
Yes, that does. Thank you.
Great. And then I think Shaban's hand was up.
Yeah, thank you. I am coming at this from a Medicaid managed care perspective and wondering if you could clarify. I know the comment earlier from the person from the State Pharmacy Association was talking about that billing code for our EDs, but in this case, it sounds like because of the pharmacy partnerships that are highlighted here, it's intended to be billed by the pharmacy to manage care, not
Correct.
by the behavioral health agency unless they happen to have a pharmacy.
Yes,
Is that correct?
yes.
So it
That's
goes
a great
to the
clarification. Yes.
It goes to the pharmacy benefit, because there are most people won't know that there are medical benefits and pharmacy benefits, but that they are different, and that's where you intend for it to be billed, is the pharmacy benefit.
Yes, thanks
in
for
this case.
highlighting that. Yeah, that's a huge, it's a great piece of clarification. You are not to, you as in the organization are not to stand up some other billing mechanism. Like, how am I going to like send in packets to this?
Yeah.
If you're partnering with a pharmacy, that's why the partnership with pharmacy is highlighted here. If organizations are partnering with community pharmacies, the pharmacy will bill it. And it is outlined in section 4 of the law as well, just in detail, sort of.
And not every pharmacy is in every insurance company's network. And is that something that you're expecting insurers, regardless of whether they're commercial or Medicaid, to accept a bill for naloxone from any insurer?
Another great question. I'm not sure if I'm expecting that. I think that probably raises some of the questions or concerns around billing for private or commercial insurance, or through private or commercial insurance. Like, will there be copays? There are copays oftentimes. Will there, some of these questions about prior authorization or denial, if it's covered at all? And then as you're saying, if they're not even partnered with, the CVS or that local pharmacy partnership, where the concerns. This is also part of, January 1st is the date this is live as a law, and we're wanting to support organizations getting up and going. And we also recognize implementation is a process, and we want to hear this iterative feedback as well. So if you're finding that the majority of the folks you're working with are getting super high copays, or things aren't getting covered, let us know, right? This is where we can come back and try to work to support you, support the people you're serving, and then also troubleshoot and work within the channels that we can to make this work for you. So I know that's a really long-winded way around to say that I'm anticipating it might be a barrier as well, but we won't know about it until these kind of get going and we hear feedback from organizations. And just one more minute left. So if you have additional, I know Julia, your hand was raised. I'll give you that. Go for it, and then we'll end with you.
This was actually a really quick question, and it was posed by one of the persons that we did a Narcan training with, and that is there any liability as someone that administers Narcan? Like, let's say if somebody has a rare allergic response to it, does the person that administers Narcan have any liability?
So the quick answer for QuickTime is under the Good Samaritan law, and that's also a resource highlighted here in the presentation that you'll see and can review. You're protected if you call for an emergency, call emergency services, or administer naloxone in good faith for somebody. So that's my really quick-winded answer to that. But also the law itself does talk about sort of protections for behavioral health agencies and emergency department staff in implementing this law as well. So I'd recommend looking at those as well in and reviewing all the these resources. And please reach out. This isn't the end of the conversation, it's the beginning. Really want to support you and your organizations, and recognize that this is difficult, but you all have continued to do difficult and amazing work. And so we're excited to work with you. And thank you so much for your time, all of you joining, and Mandy and Miriam as collaborating partners. And we will see you next week for part 2. Thank you all.
Thank you.
Thank you.